Hi guys, this is Jay again from Western University of Health Sciences, and now we're going to cover very briefly the ablation treatment. So before we begin, one thing we want to ask ourselves is why do we need to place a patient on anticoagulant therapy before ablation? So let's draw this out. We have the left atrium. Now we're in the anterior view, right? So where should the appendage be? Right here. So what we're trying to do with anticoagulant therapy is reduce risk of clot formation, right? And if we go back to Virchow's triad, I put a little mnemonic in here for us. Virchow is a he, but sure acts like a she. So what is she? It stands for stasis, hematocoagulability, and endothelial damage. So what we're trying to do is reduce risk of clot formation, most likely to occur in the left atrial appendage. So that's what we're trying to do by putting this patient on anticoag therapy. All right, so now building off that question, something else EPs will get asked a lot is, well, how do you know where to ablate? Are you just going in and burning everything down? Obviously the answer is no. We're doing it off statistics and probabilities and things that we've learned about, right? So most common, we talked about this before, most commonly the PGs are going to be found at that junction between the pulmonic veins and the left atrium, right? So if we go back to our drawing and we add in the pulmonic veins, where are these PGs most likely to be found? Right at that junction point, okay? The little dots that I'm trying to draw in green. All right, so, we briefly mentioned this before in the previous video, but I actually want to go ahead and take the time to explain the transseptal puncture. Change pen color really quick. How do we physically get to the left atrium, right? Let me draw this out again, IVC. So, as mentioned before, we're going from the IVC, usually from a femoral entry point, going to the right atrium, and right here at that interatrial septum, we need to get across. So, essentially, we're just poking through it, and that's going to allow us to access our sites of ablation. One interesting thing to note is that even if a patient has a patent foraminal valve, or PFO for short, we actually don't use it. Okay, we want to place ourselves in a position that's going to keep us proximal to the pulmonary veins, and the PFO is not an ideal location. So if we go back to our diagram now, following this red pen, you can see we're going from the IVC to the right atrium, poking across. Now we can bring all of our equipment into the left atrium. So you might be asking yourself, well, how do we actually physically perform this transseptal puncture? As mentioned previously, we're going to be using ICE. We're going to be using ICE, which stands for intracardiac echocardiography. Right, and we showed that quick little algorithm above where ICE can be used for both transseptal puncture as well as visualization of the internal aspect of the left atrium. Okay? So in this case, what we're using ICE for is transseptal puncture. So let's show some images of what this is going to look like. So IAS is going to be our septum. Here's my left atrium, left superior pulmonic vein, left inferior pulmonic vein. Now the buzzword that you'll hear a lot of EPs talk about is something called tenting of IAS. And that's how you know you have good engagement of the septal wall. So just really quick, one thing that we need to also consider is the use of a sheath. Why do we actually need a sheath for transseptal puncture? Well, just like any other procedure where we're passing equipment, we want to minimize the number of puncture sites, right? So by having a straw, or sheath, excuse me, which is essentially a straw, we have continual access without having to put in multiple holes. So a sheath is a good thing. All right, so as mentioned above, how do we orient ourselves spatially for ablation? As I talked about before, the left atrium is a 3D object, which historically has been seen from a 2D aspect, but we're no longer doing that. With the advent of technology, we're utilizing CTs, we're using mapping via lasso, as well as ICE, to really narrow down and have a targeted, specified approach to ablation, right? So this image, which we've referred to for the third time now, I really like it. Let's go back to that posterior view. What do we see in the posterior view? Let's relate to our very simplified left atrium. What do we have here? LSPB, LIPB, RSPB, and RIPB, right? Excellent. And everyone's favorite LAO view, what's in between these three structures? The ligament of Marshall. So, it might seem a little redundant when we talked about how we can create a 3D image from both CT as well as mapping. So why are we doing both? Well, one thing to consider is that with CT, we usually do it before obviously we do it before the procedure, and that's going to give us a baseline reading of the patient, right? So we're able to rule out things like thrombus, which are commonly found in where? Left atrial appendage. Also, it's going to allow us to identify the patient's unique left atrial anatomy, and it's going to give us a reference point for when we're mapping, so we can actually create a 3D image with mapping and reduce any artifact and really pinpoint what the left atrium of the patient will look like. So that's why we do both. So both is good. Smiley face. So going back to ICE, we talked about 3D imaging with CT, mapping, and internal visualization with ICE. So what would that actually look like? Well, if you look at your image right here, what we see is a 2D image superimposed on a 3D image, right? And by doing this, it gives us a more accurate representation of the internal aspect of the left atrium. And a technology that's commonly used is cartosound, okay? So it's a software algorithm that puts together the 2D with a 3D. So one thing that's really important is in ablation, we need to know at all times the orientation of the ablation. Okay, so if you look at the images right here, let me just point out a few things really quick. We see lasso, catheter, ablation catheter, lasso, ablation. So by knowing the orientation of the ablation catheter, we can make sure that when we're performing the radiofrequency ablation, or whatever type of ablation that's being used, we know the exact spot we're targeting, right? What we're trying to do is avoid picking at the exact same spot over and over and over. So by having a lasso, we have a visualization of the ablation catheter, which is going to help compensate for the fact that we're over 4 feet away from the patient's heart. We don't have any direct visual stimulus and very minimal tactile feedback. So having that orientation is going to ensure that we are putting the ablation catheter where it needs to go. And again, just to reiterate, remember we're trying to ablate a 3D structure, right? We're trying to ablate something with no visual stimulation and minimal tactile feedback. So having real-time imaging with the lasso is going to help make sure that the ablation catheter is pointing in the right direction, to keep it simple. So what are these different catheters? What do they look like? Well, just very briefly, here's the lasso catheter. Here's the ablation catheter. One technology that's recently been integrated into ablation catheters is the use of pressure sensors. It provides data on the force and time of contact. So, at this point, I think we've reached the point where we can ask ourselves, I've created a transseptal puncture and passed all of my equipment into the left atrium, so what do I actually do next? What's the next procedure? Before anything happens, what will happen is we have the 3D image created by CT as well as the 3D image created by mapping. So the EP will sit down in a nice comfy chair, and he or she is going to look at the 3D constructed CT image as well as the mapping, and they're going to compare the mapping versus CT, and they're going to remove any artifacts from the left atrium. So something that's not actually part of the left atrium, and we're going to be able to have a really nice image of what the left atrium looks like. So you could say it's something like that, right? So after ablation, what should my end result look like? Well, if you've done it correctly, it should look something like this. Around each pulmonary vein, you're going to have these single dots, and each dot represents an ablation point. Remember, given today's technology, with each dot, we can get pressure readings, force readings, as well as time of contact. Okay, so a few more things to cover. One thing we want to think about is why do cardiologists, specifically EPs, ablate the superior and pulmonary veins in pairs, right? Why not ablate each ostium separately? So let me back up for a second. We have the left atrium, pulmonic veins. As before, if we cut it in half and look down it like a barrel. Okay, so what am I talking about specifically? So let's say this is the superior pulmonary vein, this is the inferior pulmonary vein. EPs today prefer to go around the two in pairs, whereas in the past, they used to go around each ostium separately. Let me try to hide that with yellow. Right, so this yellow approach is no longer recommended. What's currently recommended is going around the two in pairs. The reason we don't do the technique where we go around each ostium, we're worried about the risk of pulmonic stenosis. So by going around the two in pairs, we reduce that risk. However, that's not to say the new approach is not with its own complications. In the new approach, what we might end up creating is an atrial flutter. Okay. And I do want to cover one more complication with you guys really quickly. Ultimately, there are tons of possible complications that can happen in this technique. One thing you'll see in the EP lab is the fear of ablating the phrenic nerve, right? So on this diagram, I tried to draw the path, appreciate the path of the phrenic nerves. And right here, what you'll see happen in the lab is when they're working on the patient, they're trying to appreciate how the phrenic nerve might be running in correlation to the left atrium, right? And that is a region we do not want to touch, okay? So something to keep an eye out for when you're in the lab. So Diana and Susan are going to cover more in depth pulmonary vein isolation. However, I do want to give a quick recap as to what the endpoint of treatment is. So what is the endpoint? What are we trying to achieve? We're trying to show a pathophysiological mechanism and a clear-cut endpoint in sinus rhythm. So what do I mean by that? We're trying to show the stable absence of any conduction into the pulmonary veins from the left atrium, which is commonly referred to as entrance block, as well as the opposite direction from pulmonary vein into left atrium, which is known as exit block. And how do we know when we have a successful block? For example, in a successful block, we want to go to a point where we have complete block, right? So if sinus is 60 and we're pacing the patient at 100, we know the block is successful if the rate remains at 60. In an unsuccessful block, what ends up happening is sinus might be 60, we'll pace them at 100. Again, if it's unsuccessful, the rate will jump to 100. All right, guys, thank you for bearing with me. Hopefully you guys learned something about atrial fibrillation. If you have any questions, please contact Dr. Ben-Zur. He's a great teacher. He loves teaching, and he'll always help you out. Don't be afraid to contact him, even if you haven't done a rotation with him. So my name is Chebe. I really appreciated you guys listening to me. I'm from Western University of Health Sciences, and I hope to see you guys in the future. Thank you. Bye-bye.
Bye.